Okay, good afternoon, everyone. Again, welcome to the New York City Latino Gay by Men's Health Rally 2020. This is our second year and following the public health recommendations and the guidelines for COVID-19 and social distancing, we are breaking our rally into two virtual panel discussions. Buenas tardes a todos, todas y todes. Bienvenidos a la reunión de salud de latinos gay y bisexuales en la ciudad de Nueva York. Este es nuestro segundo año y siguiendo las recomendaciones de salud públicas y pautas impuestas por COVID-19 y el distanciamiento social, estamos dividiendo el rally en dos paneles de discusión. A brief message in Spanish para aquellas personas que prefieran utilizar la traducción de inglés a español, lo pueden hacer a través de la línea telefónica que está en el chat. Agradecemos a Rosy Mota de Latinx Commission on AIDS por asistirnos el día de hoy con traducciones. Thank you, Rosy, from Latino Commission on AIDS, who will be translated from English to Spanish in the sign line that is on the chat. Before we start, I just want to take a moment after processing United States election this past weekend and congratulate President-elect Joe Biden and a special acknowledgement for the first woman of color, daughter of immigrants, in become Vice President-elect, Kamala Harris. We are getting too political, and regardless your political party or preference, the call we do today is a call for unity. For we, the people, we all together work for a better future. So we are ready to start. Good afternoon, everyone. My name is Luciano Reverte. I am the director of the Latino Gay by Men initiative for Latino Commission on AIDS and Oasis Wellness Center. Also with me today, we have my wonderful coworker from La Isla del Encanto, Puerto Rico, Julio Rolón Mendez, who is the manager for the Latino Gay by Men initiatives. Julio will be moderating this panel discussion. So please, if you have specific questions about the presentation, type them down in the Q&A session on the bottom of your screen if you are connected through a computer. You can use the chat for comments and reactions, but we encourage you to use the Q&A session for a specific question about the presentation, as we are going to be addressing those questions at the end of the session. To introduce today's topic and a wonderful group of panelists, I will pass the mic to my dear Julio. Julio, are you there?
Yes, I'm here.
Okay, so the screen is all yours.
Thank you. Let me just share my screen. Okay, so good afternoon, everyone. As Luciano said, my name is Julio Arnaldo Rolón Mendez. I work as a program manager on the Latino Commission on AIDS. So today we're gonna have a discussion about HIV stigma and COVID-19. And for talk about these topics, we are going to have a panel of four professionals in this area. So the panel is going to be about the importance of U equals U in the times of COVID-19, and how U equals U also is used to combat stigma and barriers to reach an undetectable viral load. The panelists also will discuss how COVID-19 is impacted the Latinx Gay by Men communities and HIV-related stigma connected to U equals U. The topics that we are going to cover today are going to be U equals U, HIV stigma. We're going to talk about the religious leadership program from Latino Commission on AIDS and the impact of COVID-19. To start, we have Dr. Carlos Rodriguez Diaz. He is a bilingual and bicultural community health scientist with over 15 years of experience working in Puerto Rico, the United States of America, and the Caribbean region. He has led several programs and studied addressing the health inequities among populations made socially vulnerable, including Latinx people with HIV, living with HIV, incarcerated populations, and sexual and gender minorities. He is currently conducting studies exploring social factors affecting COVID-19 epidemic among Latinx in the US, including Puerto Rico. Dr. Diaz is an associate professor of prevention and community health and director of the community-oriented primary care program at the George Washington University. Milken Institute School of Public Health. Carlos completed a postdoctoral training in HIV and global health research, a PhD in public health with a major in community health education, and a master in public health in health education. He has also completed postgraduate training in health policy, human rights, and health diplomacy. So virtual applause. Following, we have Luis Nava Molero. He's a community health educator and a group facilitator for the Latino Religious Leadership Program in the Latino Commission on AIDS. Prior to his work with the Latino Commission on AIDS, he was an outreach specialist and group facilitator in the New York LGBT Center, focusing on immigration support and immigration social action activities. His work helped connect new immigrants with services and programs to help them establish successful lives in New York City. Luis also worked as a client outreach specialist for AIDS for AIDS International in New York. He conducted client home visits and developed database that helped social workers improve service to clients. In his native Venezuela, Luis had a career as a professor of political science and international economics at University Simón Bolívar in Caracas. He holds a master's degree in political science from Ball State University, and he was a Fulbright scholar at the Speaks in Spanish, Russian, and English. So warm welcomes to Luis Nava. And also we're going to have Anselmo Fonseca. He is a New Yorker born in Brooklyn 58 years ago. He's a self-identified gay Hispanic man who is a long-term survivor living with a positive diagnosis of HIV for almost 30 years. His work has been recognized by Pulse Magazine Top 100 in 2010, and the Obama administration as one of the 350 most influential national advocates during the launch of the National HIV/AIDS Strategic Plan 2010. His advocacy spans over 20 years, defining some of the most marginalized communities cast aside by mainstream society due to stigma, discrimination, and indifference in Puerto Rico. He is the Ryan White Part B community co-chair for 10 years. He mentors 9 people living with HIV peer representatives on the many aspects of strategic planning and Ryan White quality care program, and participates in an 18 stigma campaign in 2018. After surviving Hurricanes Maria and Irma, Anselmo is officially AIDS United Program Manager in Puerto Rico, and he is also ambassador of the U equals U campaign. In Spanish, I equals I, or indetectable, es intransmitible. His knowledge of system in asset of AIDS United, as he also supports grant making, developing Hispanic Latinx initiatives, and has key role amplifying the voice of Puerto Rico with local delegates of AIDS United Public Policy Committee. And last but not least, we have Jose Javier Martinez. He's a professor, certified health educator, social researcher, and public health professional. Born and raised in Puerto Rico, he has a master's degree in public health education from the Graduate School of Public Health in the University of Puerto Rico. For over 5 years, Mr. Martinez has worked developing health promotion interventions in the field of LGBT plus health and HIV prevention and stigma and gender equality. In collaboration with community-based organizations, healthcare centers, and education institutions, he has designed and implemented programs tailored to promote inclusion and welcoming environments. Currently, he co-leads the Office of LGBTQ Services at the AIDS Institute in New York State Department of Health. So welcome, Jose Javier Martinez.
Thank you. Thank you so much.
So now I'm going to stop share the screen so we can start the discussion. To start the discussion, I want to give a few definitions because in other work that I have done, there are a little bit of confusion about what means undetectable and what means very suppressed. So to begin today's discussion, I want to define what U equals U, a little bit of the history. In the studies of partners, opposite attracts, and partner two from 2011 and 2016, viral suppression was defined as less than 200 copies of HIV RNA per milliliter of blood. But when standard viral load tests cannot detect copies of HIV, an HIV positive person is said to have an undetectable viral load. Most of the results used clinically today, this means that fewer than 50 copies of HIV per milliliter of blood that means to be undetectable. So because of the studies mentioned above, the U equals U was created. So the undetectable equals untransmittable. This message empowers people living with HIV to care for their health by getting and remaining undetectable. Also, dissembling the HIV stigma that has been in the field since the start of the epidemic by challenging the assumption that people living with HIV pose a risk to others. Although this message is important to society, it is still not widely known due to various healthcare landscape barriers, such as political, economic, and systemic obstacles. Due to these barriers, the risk of people with HIV have been exaggerated, putting in many people with HIV at risk of harm and injustice. So my first question is going to for Carlos Rodriguez. And I want to know, how does U equal U impact stigma faced by people living with HIV and AIDS?
Thank you, Julio, and thank you for sharing a definition for U equal U as an initiative. So in principle, U equal U is a fantastic approach in reducing the negative impact of stigma towards HIV and towards the populations affected by HIV. It is good because it provides a template to provide HIV services and sexual health services, regardless of the status of the individual being benefited from the services. However, I believe that one of the challenges that we have with the U equals U initiative is that theoretically it's very good, but we need to translate from the theory that it represents to the practice at the clinical level, so individuals can actually benefit from it. Otherwise, it's just the use of research findings, the use of good practices, but only at that level, just at the discourse level. We need to translate that into the practice. And that requires challenges associated with that requires changes that are associated to the training that our healthcare providers have, just doing things in a different way, acknowledging the importance of knowing the status and how to link to services regardless of having an HIV negative or an HIV positive status. And I think that for the clinics also is an invitation to strengthen their services for HIV prevention. And I mean this for clinics that are historically known to provide HIV or STI services. They need to strengthen the HIV prevention arm so people who test negative can remain engaged in care. Because I think that over the years, we've been very, very good in creating services to sustain services and retain people who are HIV, who are living with HIV in care. But we need to translate that knowledge to retention in HIV prevention services.
Thank you very much, Carlos. And as part of this discussion is as you said, it's important to translate. And that is something that, to put it in practice, I think that is really, really important to translate it, because then we can understand it better. So the U=U campaign provides a prevention strategy to those lives are affected by the virus. For example, reducing the anxiety associated with testing, encouraging people living with HIV, offering a clinical public health argument in advocacy on universal access, and transforming the social and sexual and reproductive lives of people living with HIV. So, in the other hand, the churches have strengths and credibility, and they are grounded in the community, especially in the Latino communities. So this offered the opportunity to make a real difference in combating HIV and AIDS. So based on what Carlos said in translating and making also in practice, some studies of the impact of religious people living with HIV have found that the participants who identified the religion as important to them showing the highest HIV AIDS stigma levels. Furthermore, some that consider religion important and participating in such activities scored higher on 7 to 11 HIV stigma subscales. For example, number 1, being fear to becoming infected through social interaction. 2, the idea that people with living with HIV are responsible for the infection. 3, believing that people living with HIV should be obligated to reveal their status to others. 4, interpreting people living with HIV as vectors of infection for the rest of the society. 5, that personal characteristics such as promiscuity and irresponsibility cause the infection. 6, having more negative emotions associated with people living with HIV. And 7, the need to establish social controls for over people living with HIV. So on the contrary, participants in the no importance or no participation group identify that significantly less HIV stigma because of they select they don't participate in any religious or any kind of activities regarding religion. So I know that Latino Commissioners have a program for addressing stigma, and also have the Latino Religious Leadership Project that work with this sector. So I want to ask Luis Nava, what strategies the Latino Religious Project is implementing to address HIV-related stigma, and also can you briefly describe the Stigma Institute that you did recently during this time of the pandemic with this sector? You are muted.
Okay, yep. So thank you so much for the invitation. But before starting or beginning talking about our program, I would like just to add to what Dr. Carlos mentioned before about the useful or what U equal U means for people living with HIV, but also for the rest of the community. In my opinion, as a person living with HIV, I would say that U equals U also represents a hope and actually a tool that reduce the stigma and give, how can I say this? So promote for people that they haven't take any test, HIV test, to promote them to go and being tested. And also it is a very important tool against criminalization of people living with HIV. I think these are two other points that I would like to add to what Carlos already mentioned. Talking about our program, so we know that most Latino people or the Latino community is more likely to report a formal religious or faith affiliations. So that means faith and religion plays a big role into the Latino community lives. And that is why we, in our program, we try to be a bridge in between a science and religious belief. We are not trying to change the religious belief that people already have. What we are trying is to promote a non-judgmental support for people living with HIV. And we think that churches play a huge role doing this. And also, when people come to churches and through our program, we are making the churches to become trusted information resources for people, for people in general and for the community. Many of our participants that have attended the Stigma Institute, we have once a year, they have told us that they have moved from position of silence, for example, and position of condemnation of people living with HIV, and they told us they moved to a different position of education, position in which they try to also to share the information they already have with the rest of the community. However, this is the good part or the good side, the positive side of what we have been doing, but also we need to recognize or to admit that is still, we still face opposition in some of the senior pastors, because for these senior pastors and conservative section of the churches, you know, it's very difficult for them to speak about sex, to speak, of course, to speak about homosexuality, to even mention in churches, in our speeches, mention the use of condoms. That is one challenge that we have, but I think, but even though that is important, we are creating opportunities to speak about HIV and to speak about how to have a safer sex in our community.
Thank you, Luis. And we know that that is something that really important for the Latino communities, because religious is part of the areas that we congregate, especially now because of COVID. It's like that is part of making community. So based on that, on the education area, I want to mention a study according to Bauer that almost 8 to 10 HIV patients in the United States report feeling internalized HIV stigma. Also, nearly 2 out of 3 say that it's difficult to tell others about their HIV infection. Nearly 1 in 4 say that being HIV positive makes them feel dirty or worthless. And roughly 1 out of 3 reports being guilty or ashamed of their HIV status. So to understand and manage internalized stigma in people living with HIV, I want to ask Jose Javier, can you describe barriers to reach an undetectable viral load, and what can we do to overcome those barriers?
Sure. Thank you. So when we're talking about barriers to actually for a person to reach an undetectable viral load, so we need to talk about 2 types of barriers. So we need to talk about the structural barriers, about the access to those services, how easy or how close or how near a person can find a place to go and receive services, and actually not only the type of service that they receive over there, if not about also about the interaction with the providers. Because sometimes we have, and we have seen that before, that the providers can be very knowledgeable about treating HIV. They will know everything about the treatment, what is needed for the patient to actually be tested regularly, but sometimes the patients feel that they are not listened to, or they are not taken into consideration when they're making decisions about their treatment. So that's actually a huge barrier for so many people, that they feel that they're not part of their treatment. And also to the other side, we need to talk about more barriers that the person may have, as for example, we need to talk about mental health issues, or we need to talk about the level of health literacy. As we all know, when we talk about HIV and we all talk about any other infections, some providers tend to use very highly technical concepts because they know what they're talking about. But they need to be sure, they need to ensure that actually the patient is understanding what I'm telling them. And they need to be sure that actually what they're saying in a very simple language. And that at the end of the day, the patient will recognize, oh, all right, I need to do this in order to stay healthy. So that's another, that's a huge barrier that we have seen before in regard to the level of health literacy of the patients. So we need to talk about all of those messages. And I would like to say also in regards to U equals U, I think that it has changed the narrative about having HIV. It has changed the narrative of feeling that I'm a risk to others, that I'm infectious, in a way of empowering myself. And I think that many providers, they need to rely more on talking about U equals U as a way of motivate the patient to keep in treatment. But however, we also know that for some providers, it's still very difficult to talk about the sexual practices of their patients. And sometimes they don't go into that because they don't feel comfortable talking about it. So I think that providers, we have done a lot in providing capacity building and technical assistance, but providers, they do need to, and I was talking about this with a colleague. I know that when we're providing a service to treat HIV, usually providers are very focused on getting the right numbers. All right, so your labs look good, we have the viral load suppressed, but then they need to also consider that we need to humanize the provision of services. It's not only to get the right numbers, it's to actually know if the patient is feeling all right, and to know what else is happening in people's life in order to help them to actually reach and maintain a suppressed viral load. So I think that those are, from my experience, one of the major barriers that we need to keep working with.
Thank you very much, Jose Javier. And it's true that some of our, for example, I did a few interviews after this pandemic about the impact of COVID-19 in people living with HIV. And some of the participants mentioned that they only receive clinical services when they also need more from those services, like for example, as you say, the humanized part. They just felt like, okay, just go to the lab and you are okay, and that's it. They don't talk about anything more. and also don't talk about the adherence or how are you feeling or how are you doing. So that is something that I think that should be included. How do you?
Yeah, and so, sorry, and we have to also recognize that, yeah, we live in a, actually, sometimes providers, they have many or multiple patients that they need to take care of. And sometimes they don't have enough time to actually go through everything with their patients. But I think if we can make an extra effort to, we don't have to ask 10 questions to the patient because we don't have the time. But if we can ask something else besides talking about the lab results or talking about the treatment, it will make a huge difference in the interaction. And actually the patient will feel, or the client, it will feel like, oh, they're taking into consideration how I feel. They are recognizing that I am a human being. So that's a huge difference in that regard.
Thank you. So I want to talk a little bit more about stigma. And in a study made by Vainon, Carey, Blair, and Littlewood, the stigma was associated with depressive symptoms, receiving psychiatric care, and graded HIV symptoms. It was also associated with further adherence and more frequent status disclosure to people other than sexual partners. Stigma is associated with psychological adjustment and adherent difficulties, and is experienced more commonly among people who disclose their HIV status to broad range of social contacts. Also, according to the video, Calawi and Beach, healthcare provider stigma can operate conscious, explicit, and unconscious, implicit in levels. However, providers who don't consciously endorse stigma can nonetheless harbor such attitude in a conscious level. Likewise, another study found that the impact patient providers interactions. Providers with higher implicit stigma verbally dominate conversation and less patient-centered, which could compromise communications around U equals U. So I want to ask Anselmo, can U equals U contribute to developing other forms of stigma or discrimination against people living with HIV who cannot achieve undetectable viral load?
Thank you, gracias, Orlando, and thank you for everyone for inviting me to be on the panel today. Good question. Yeah, recently we've seen and heard, yes, that there is a certain impact, that it's an unintentional impact, because we do know that while clinically we all aspire, right, to be and achieve viral suppression, we know that there are individuals that have started their treatment very late in their course, for which reason many will not be able to become fully undetectable or virally suppressed in that aspect. And so, yeah, it's becoming an issue in the sense that because you have a viral load, you are not worthy, or somehow you are less than, you know, an ideal individual. And no, that's not, you know, what the intention is. The intention is to be a hopeful message, one of inspiration, to make sure that people realize that they're not alone in this journey. It is one that is full of struggles on a daily, you know, day-to-day matter. So, you know, having to have at least a positive messaging around how we can continue to be part of a social norm, removing those stigmas of being infectious, being AIDS, not being seen as HIV, which uncontrollably can become a diagnosis of AIDS. You know, we all live with HIV, you know, nowadays, and we're all, like we say in Puerto Rico, gorditos y colorados. We're healthy individuals. You know, we're no longer, you know, dysfunctional individuals in society, you know, that are looking to be revengeful and make everyone else sick. Those days are long gone. We all want to become productive individuals, and we want to rebuild a better society. And we know that change comes through education, and education is something that has to be a constant in order to achieve this. So yeah, we understand that it can be seen at UU as lopsided messaging, but it is one that was basically rooted in, you know, hope and being able to liberate ourselves after many, many years of being seen as untrusting individuals that cannot have safe sex or be responsible enough to carry on our routine daily lives.
Thank you for that, Anselmo. And I know that there is not like a lot of studies yet about other stigma after U equals U, because when it started with PrEP, then another stigma start like creating, like, because of the PrEP use. The people start, you know, shaming people that are openly more about, okay, I'm going to use PrEP and not condoms. So now it's more related about being undetectable. So, and it's something that is being shown on social media and social apps. That is something.
Yeah, no, I was just going to add that clearly, you know, the UU messaging is not one that's strictly, you know, one that is fortifying or looking to advocate for unprotected sex, because, you know, if it's a good, in that sense, it's a good messaging of being able to be a little more liberal with your intimate partner or partner if you're in a monogamous relationship, which is of course preferred, but everyone to his own. We are basically, you know, trying to say that if you're going to protect yourself against HIV, this is one of the best ways to make sure that you go about it. And of course, if you are going to, as we all hope, continue to also not want to acquire other STDs, then you're definitely going to want to make sure that you practice safe sex. Are you wearing condoms as well?
Yeah,
There's no
that's
one
true.
size fits. There's no one size fits all for anything now.
Yeah, yeah. So, and also I want to talk a little bit about the, now that we talk about stigma, and we know that with all the information of what the panelists have shared, that U equals U, it's not only good for prevention, but and to maintain adherence, but also to help people understand that being undetectable, make them health system more strong. So we are still learning about the COVID-19 impact and how it affects people living with HIV. So based in limited data thus far, we know that people with HIV who are on effective HIV treatment has the same risk for COVID-19 as people who don't have HIV. But still, people living with HIV spend similar amount of time in hospitals as negative COVID-19 patients. They had compared death rate during the height of the outbreak in New York City, and they still are more likely to put on ventilators according to a study presented at the 23rd International AIDS Conference. So I want to ask Jose Javier, does U equals U contribute to easing the feeling of vulnerability to COVID-19 among people living with HIV, and how it contributes?
I think it does actually. People, as you just said, we don't have all the data in regards of, because actually they're still conducting studies. Actually, at the AIDS Institute right now, they're conducting a study to know if actually people who has been hospitalized or people who has been diagnosed with COVID and also has HIV. So they're studying if there have been any correlation between that, but we don't have all the data as of so far. But yeah, but U equals U, actually it does help with feeling more strong in the facing another pandemic as COVID, because as you just said, even though we don't have all the data, we need to talk about how is our immune system. So if we have if you don't have a compromised immune system, we have a strong immune system, so we can actually combat the COVID in a better. So in that case, yes, that's another of the benefits of U equals U, of having an undetectable viral load. And that's something else that the providers can talk with their patients. That will be a great motivator for patients to be adherent to treatment, because not only it will give them the sense of peace of mind that actually there will not be any transmission of the virus sexually, but also it will give them the security of that they will be in a better position in the case that they will be exposed, or in the case that they actually will contract the coronavirus. So yeah, that's another benefit of U equals U.
Thank you, Jose Javier. And that is something that, as Anselmo also said, that is something that we can feel empowered, but not also, it's not like when you said like using condoms, it's not something that fits to everybody, but there are still people that, because if you look on the internet, you still find those old information when the COVID-19 was started, that people living with HIV was a more risk. And that is not something that you see on the internet, that this is not updated. So that is something that it's really important to know that it's not only for having sex, the U equals U campaign. This is also for empower people to maintain their health and to keep taking their meds. So talking a little bit more about COVID-19, I have a few statistics about the impact of COVID-19 in different populations. For example, in New York, the data so far shows that in the poverty level, the people with the highest poverty level suffer more than the lower poverty level. For example, in the rate of people, the highest poverty, the very high poverty, 74 people per 1,000 rate, they suffer more of the death of COVID-19. In the regions that these people live are the Bronx, the Queens, and Brooklyn. So, and the population there compared to the other parts of New York are poorer. The cases by ethnic and race, the rates were 2,084 per 1,000 people. The blacks were 883 per 1,000 people, and the white were 1,332 per 1,000 people. So, and the mortality rate were higher in the Latino community. So data doesn't show the impact of the COVID-19 specifically on people living with HIV or in the people in the LGBTQ plus communities, specifically just by the Latinos and the people that have the very high poverty or high poverty level. So I want to ask Dr. Carlos Rodriguez, why has the COVID-19 disproportionately impacted the Latinx community, and how it impacted the gay bi men's health?
So Julio, thank you for sharing the findings from the different studies that have been conducted so far on COVID in Latino communities. So the answer to your question is the social determinants of health. We have created social conditions that increase the risks for racial and ethnic minority groups in the United States to have a higher likelihood of getting sick and die. And unfortunately, we are seeing that during the COVID pandemic. So there is nothing inherently in the Latino community that is a precursor for COVID infection or COVID death. Are the social conditions around being Latino in the United States. And in fact, a study that we conducted also evidence that different group of Latinos in different places of the United States are having different experiences when it comes to the COVID pandemic. Because if you are a Latino in the Midwest who is monolingual, not speaking English, and have no access to care, or is not undocumented, the risks to getting infected and also progress to death are higher. And that's because there are different occupational risks. There are different models or avenues for accessing care, and housing quality is a significant precursor that explain the disparities that we see within the Latinx community. I would like to mention that we personally haven't done research comparing gay, bisexual men to other groups when it comes to risk for infection and death. However, we are seeing a significant impact of the pandemic in access to HIV care and healthcare overall. We have seen an impact in use of PrEP and questioning, like, I'm in lockdown, I'm not having sex, should I stop PrEP? When should I restart PrEP? Should I restart PrEP? What about if I run out of PrEP? So we were not ready for a pandemic. We were not ready for lockdowns. And we are learning a lot. We are creating a lot around the HIV continuity of care and for HIV prevention as well. And we had to adapt to being unable to provide the services that we were planning to. And I also wanted to add that for people with HIV, in our studies, we have we've been able to incorporate the HIV status of individuals in our analysis. And so far at the population level, we haven't seen a significant disparity when it comes to COVID infection and COVID deaths among people who are living with HIV. However, those models are created to understand different risk factors. So HIV is considered as other risk factor, like pulmonary or asthma disease or cardiovascular diseases. So we've been controlling and analyzing what could be the role of HIV in the outcomes for people with HIV and COVID. And we still have a lot to get to know and understand. Early in the pandemic, I would say probably 4 months ago, there were some theories about why people with HIV are not progressing faster or are not seeing disproportionate burden of the pandemic. And some theories or hypotheses were considering the role of antiretroviral therapy in having some level of protection for people who are HIV positive and experiencing COVID infection. Similarly for people on PrEP, because the medication used for pre-exposure prophylaxis is an antiretroviral therapy. So perhaps a person with PrEP or using PrEP might have a different experience in terms of symptomatology when infected with COVID. But we don't have enough information yet to claim anything. And unfortunately, we would need people to get infected in order to do research. And at this point, I rather protect people from not getting infected with COVID. And I would insist in COVID prevention rather than studying what is the impact. Ideally, within the next year or so, we will have a vaccine and people will be protected for COVID. But in the meantime, we are learning. And the good news is that over time, we should have more information. So we can use it as part of our resources for the well-being of our Latinx communities.
Thank you, Carlos. And I think that it's important to discuss the social determinants of health, because it's something that sometimes we heard what they are, but not necessarily we understand what they are. So as also you mentioned, factors as poverty, racial discrimination, limitation to access healthcare, to language barriers, and low educational level. So also immigration and status and mistrust on the healthcare system affect the quality and quantity of the services that the people receive. So talking a little bit more about people living with HIV and AIDS, we know that we still don't have the information, but and all the studies. But if Anselmo Fonseca, can you answer me? What have been the areas of greatest impact of COVID-19 in people living with HIV?
Well, there, there are multiple ways to look at it, right? But clearly, you know, being in lockdown situations are not ideal for any individual. We are social individuals, right? We're a social race. We are interactivity is built into us, especially Latinos. We're very lovable individuals. We love to hug and kiss each other all the time. So yeah, not being able to socialize amongst ourselves and our brothers and sisters is something that's clearly affecting our state of mind. So many are being depressed. Clearly more so after the COVID lockdown, while many of us do live with depression at many levels on a day-to-day basis after a diagnosis of HIV, among anything else like earthquakes and hurricanes and elections. Yeah, we know that stress is something that is not very helpful to our well-being. So we tend to continue to reach out for others. Social medias have become very key in that sense to making sure that we, although are originally kept, we're told to be socially distanced when appropriately it's physically distancing. We encourage people to continue to be socially distanced. We need the support of each other in order to get through tough periods in our lifetimes. So these life-altering events clearly affect us all. And yeah, there's been quite a bit of outcry on social media and apps for interaction and connectivity of our Latino brothers and sisters that want to be with others. Even in times when we can't, there's always some sort of guidance around how we can do things in a safer way, while not encouraged. Yeah, social interactivity becomes physical at some point or another, especially in times of COVID, as risky as that can be. But yeah, it definitely has had an impact in our quality of life.
Thank you, Anselmo. And I also want to talk a little bit the impact of the stigma, not only regarding HIV, also about COVID. Stigma is associated with a lack of knowledge and about how to COVID-19 spreads. And need to blame someone, fears about disease and death and gossip and spread rumors and myths. Stigma can lead to labeling, stereotyping, discrimination, and other negative behaviors towards others. So I want to ask Dr. Carlos Rodriguez and also Jose Javier if you can talk a little bit more about, is HIV stigma similar to the HIV, to the stigma faced by people diagnosed with COVID, and how it is similar or is different? And what strategies are being implemented to address both stigma?
That's a very interesting question. And to be honest, I don't think that we have research that we can cite that support our opinion. But I will speak from what I have seen in working with community-based organizations here in Washington, D.C., and also the work that we are doing in Puerto Rico with people living with HIV, particularly gay men living with HIV. No, the stigma is not the same. The causes, the stigma by itself as an experience is negative, right? But it's not the same, because stigma is used as a tool of power based on the differences of the other. And the people that are at risk for HIV and the people who are living with HIV, because of different reasons, are experiencing, are also people who have been socially vulnerable for being gay, for using drugs, for having multiple sexual partners. So that increases the stigma, because it's not only for living with HIV or at risk for HIV, but also because of their identities and what they do. And for people with COVID, I think that because it's been more generalized, people has been seen more as victims, as a result of something that you've done to put yourself at risk. But what puts you at risk are really things that we do and that we our actions are not identities, like not wearing a mask, or I don't know, not washing your hands. So our behaviors, not identities, and therefore the weight of the stigma is different. Again, I'm speaking very broadly based on the identities and experiences and what we know about the COVID pandemic. I think that it's a great research question. I would like to hear what Jose Javier has been hearing, because I know that he's been in the front line testing for COVID. So I'll let you say.
Yeah, definitely, I agree. You cannot compare at all what people with HIV actually experience in regard to stigma or those experiences. However, what I have seen, like working, like conducting all this in these testing sites and interacting with people who have contracted the virus, is that you may see some similarities in the sense of, for example, a person that I know told me that actually someone else knew that actually that person was diagnosed with COVID. So actually some of his friends and co-workers and people in the area put a sign on him, like he labeled him as the person who has the COVID, who has the virus. So that's one of the experiences of that we can talk about stigma, that actually sometimes people labeled the other as the threat, as that I cannot interact. And there's some experience of rejection when people actually has been diagnosed with COVID. Also in the regards, I don't know if you remember, but during the first month of the pandemic here in New York, Asian Americans, they suffer a lot of rejection and discriminatory actions, because actually for many people, they targeted Asian Americans as the one to blame for bringing the virus into our state or our areas. So that's another similarity when we talk about stigma. But no, it cannot be compared, but you can identify some similarities. I think that definitely there's a lot more that we need to study about it. We're just in the beginning of all the situation, but I think that some people have suffered from experiences of feeling discriminated or rejected because they have been diagnosed with COVID.
Thank you. And that is something that I have experienced, because I think that also because the lockdown, most of us being like in our houses and sometimes experience stigma, you need to go and interact with people. So talking a little bit more about the lockdown, I want to ask Anselmo and Luis, is there any positive impact on the lockdown because of COVID pandemic had on people living with HIV? Can you talk about a little bit more? Because there is a study that they found positive impacts, but in the general population, like for the entire lifestyle changes, practice of hygiene, they change their diets, they maintain more communication with their loved ones, and that study found different kind of positive areas, not necessarily negative areas because of the lockdown. Can you talk a little bit more about if you experience, for example, in the religious leadership program, about positive impacts within the community or in the people living with HIV?
Yeah, Julio, it's a kind of tricky question to answer because, as you already mentioned, it is difficult to find so far studies or statistic or data regarding this issue. But based on what we have heard from our community, I could just mention, for example, that number one, it's not only about the positive impact, it's actually the positive attitude people living with HIV have shown during the pandemic time is that people living with HIV already, I could say, are used to deal with an epidemic, are used to deal more effectively with different health protocols, because people living with HIV, especially those of them or those of us that have been living with HIV for a long time, we already take good care of our health. We are familiar to, or we acknowledge the importance of having good hygiene habits. But beside of that, I could mention that also one positive impact is that solidarity that the congregation of faith have shown up, okay? And not only regardless or regarding or related to people living with HIV, but in general, okay? On one hand, we have a negative impact that I think Anselmo was mentioning, is the isolation that all of us have experienced, because now, and we know that people living with HIV, one of the main problems is the isolation, right? The social, he mentioned, I don't like either that phrase, social isolation or social distance. No, we are not distant. We just have a health distance from other people, but we need to fight the isolation. And that is one important positive consequence or positive impact of this pandemic, is that, once again, I will repeat and conclude with that to let Anselmo to add anything else, is the, gosh, I cannot say it in English now, the solidaridad, okay, in between all the people.
Yeah, Luis. Great question, Julio. I kind of see it as sort of as a blessing in disguise or a silver lining, because it has helped to propel the community at a grassroots level to be more supportive. Historically, we've complained about lack of, support groups and support systems, and we've basically all done that. We've all, looked inwards and stretched our arms out to reach out to friends and family, and continue, to support others so that they can support others. It's a very domino effect in that sense, and it's that social isolation has been key for a lot of people to also look inwards and reevaluate, what's important, what are frivolous things that we don't necessarily need in our lives, getting back to basics. We are experts at surviving epidemics. We know old and very easily adapt to new protocols for healthcare. So yeah, you know, I think we are definitely a wealth of knowledge and experience that we can share with many of our peers. And you know, social media is there. Let's make the best of it. You know, again, you know, grassroots mentality. Don't wait for others to do it for us. We need to do it for ourselves.
And also, I would like to add that because that's a very interesting question. That at first you may think, oh wow, I think that there's nothing positive out of the pandemic. But I think that one of the positive aspects out of it is actually it has, number one, is highlighted or put it out there on the surface all of the existing health disparities that has been affected our communities for decades. So we all know about that, but I think when we talk about mainstream, some people may not know about all of those health disparities. So it has helped put out there and highlight the situation. And I think that the second good or the second positive aspect is that I think that as Latinos, we have come together in order to help each other. Because I think that there's a very important thing that we have to take care of ourselves. We have to keep practicing all of the measures in order to prevent the virus, but also we can do a lot for our communities, for our neighbors. And at the end of the day, we need to talk about more how as a community we can be healthy and more as an individual, because at the end of the day, we're interacting all the time. And if I'm healthy, my neighbor and my community is also healthy. So I think that's something else that is, I think it's great and positive out of this pandemic.
Thank you all, and I think that is important to take also the experience of the people living with HIV in their resilience and how resilient we are, and also the Latino communities and migrant communities, because it's something that it's all the time happening in our lives. So and how this experience is, we took other experiences, the other things that we learned and applying for this moment. So during this panel today, we discussed about U equals U and the importance of the message and the tool that we have to combat stigma, how stigma impacted people living with HIV, and also people that were sick with COVID-19. We talk also about the barriers that people can face to reach an undetectable viral load, and how also social determinants of health can facilitate or be a barrier to access health, and also the education and the interaction with the providers. And we also talked about the impact of the COVID-19 in the communities. So now I want to ask all the people that are in the audience to use the Q&A question, and also you can do it using the chat to ask questions to the panelists. We have now one question, and it is, how can we help Latinos not reach medication fatigue and keep pushing the message of U equals U? So it's open. Who wants to answer that question?
All right, so I'm going to start. I think that the medication fatigue or treatment fatigue is real, and it may has a great and it can affect deeply the treatment. I think that first of all we need to providers, they need to actually keep working with their patients, keep working together in as a way of helping them to recognize that by being adherent to the treatment is the only way to actually live a long, healthy life. And actually, but also it is important to recognize that and tell the patient, you are telling me that you have fatigue to the treatment, you're telling me that you are kind of tired of telling their treatment, and actually recognizing those feelings, not overlooking that. So, and actually talk to the patient about how they feel, what else can I do or not to help you with the process. I think that actually can make a great difference, and actually can help the patient to overcome the treatment or medication fatigue, and also make the necessary referrals for that patient to look out for other services as counseling in order to help them to keep in being adherent to treatment. In regards to U equals U, I think that what we need to keep doing is keep talking about it. Keep talking about untransmittable equals undetectable equals untransmittable. We need to actually put it out there, talk with our colleagues, our providers, our friends, because that's the only way that actually we can make the concept more appealing to people. Not feeling so technical or scientific, because actually in order for someone to feel or to keep being adherent to treatment, the patient, they need to recognize, all right, what is out there for me? If this is something that actually is going to make my life better. So that's what we need to do. We need to keep talking about U equals U and the benefits of being adherent to treatment.
Yeah, and also I would like to what Jose Javier already mentioned, that people can have or present this fatigue based on different reasons, on different factors. I think it would be important for health providers, social workers, everybody, even community leaders or people that work with people living with HIV that present this treatment fatigue, is to have an intersectional approach and to see why is this person manifesting or presenting this fatigue. If it's because the person is depressed, it has to be with any emotional issue specifically at that moment. And the main message we need to keep in mind, as Jose Javier already mentioned, is that this treatment is saving your life. This treatment is keeping you alive. It's keeping you healthy. We need not to forget that at any time.
Yeah, I would say I agree with what my colleagues all said, but also we need to keep in mind that simplification of treatment, you know, multiple pills versus one pill a day is got to be the first thing that is, you know, taught and, you know, negotiated with our peers, because many are still stuck in, well, if it's been working for me, why change it? You know, and not necessarily are found with providers that can clearly delineate to them that, okay, well, that worked at that point in time and good, it's still working, but there were side effects that you have been dealing with for so long that could be actually causing you more damage to your health in the long run. So, you know, start with that dialogue, you know, and see, before even thinking that it may just be something that's, you know, an emotional issue that the person has to overcome, because it may just be simply as simple as carrying 5 pills 2 times a day versus, I'm exaggerating, of course, but I do know some individuals that still do, versus just one once a day. You know, sometimes 2 pills 2 times a day or once a day may also not work. So, you know, I mean, we need to simplify the therapy as much as possible before we seek any other avenues for non-adherence. And of course, having, I don't know if you want to put it this way, but we can use you as a carrot on the stick. You know, this is how you get there as fast as you can. You know, let's get you on good treatment. If you're, you know, you're willing to do this, let's get down this road, and I'm sure in record time we can get you undetectable, you know, and if not, then we can see why not when we get there. So be clear, and also keep in mind that language matters. You know, providers, we love, you know, we love our doctors, and we have lifelong relationships with them because they're there for us, right? our moms and our dads, but other than that, our doctors, they're the only ones that are really there for us. So we need to have that buy-in and that trust, that confidence level to be able to have those dialogues. And keep in mind that, yes, we all grew up in the HIV world in the early 80s, but as well as the virus mutates and resists every effort we make against it, we also need to keep in mind that language also needs to evolve. So make sure that we don't use insensitive words as infection when I'm not your patient and we're not in your clinic, you know, and things like that. There's things that really do matter and make a difference to people, you know, using words like statistics and data, very intimidating to individuals, you know, at grassroots level, especially if you come, you know, from very poverty-driven communities. So we need to, you know, make sure that we talk down, not down, but be simple in our words and make sure that everyone gets the messaging as clear as possible in order for our efforts to be effective. Thank you.
Thank you. I also have another question from Henry Peralta. Everybody wants a vaccine. How do you address the vaccine trials to the Latino community, knowing already that there is a stigma in some groups?
Or are they referring to the an HIV vaccine, or it's more about a COVID vaccine?
I think that is about a COVID vaccine, but that is my interpretation. But Henry said both.
You know what? I'm not an expert in regard to the vaccine trials and all that process, but I think based on my experience as a health educator and working in the public health field, I think that what we need to keep doing is we need to keep providing accurate and reliable science-based information to everyone, to the community. So actually the community knows what's out there and knows everything about both infections. And also that's from my experience, that's one of the biggest ways of actually tackling down stigma. It's providing information, because I know that some people also people tend to react when they don't know all the details or the data regarding the virus. So I think that providing more education, doing more training to PCP or primary care providers in order for them to being able to assess or counsel their patients in regard to HIV prevention. So I think I will go with we need to keep doing it, providing more education and putting the information that is reliable and evidence-based out there. Because now in 2020, we can access information very easily. It's just like a click and we are going into any navigator. But the problem with that is sometimes we don't find the information that is accurate or reliable. We may find any information. So I think that's a challenge that we have healthcare providers to be able to reach out to the population and to tell them and to give the information in a way that actually they can understand it.
Thank you. Another one wants to bring another suggestions on how to address this kind of stigma.
I would like to add a short comment. As Jose Javier already mentioned, the most important tool we can have to fight any kind of a stigma is education. And specifically talking about the trials for HIV, not in this case, I will talk specifically about COVID trials, right, for the vaccine, is that we need to be, as a Latino, we need to be represented into the trials. So because then, if when the trials are being doing, so and you have Latino representation in there, then maybe it can, after that, it can appear some side effects that we didn't study during the trials because we didn't have enough Latino representation into these trials. And that is valid not only for this vaccine, but for any vaccine. So different segments, different ethnicities of the population need to be represented into the trials.
Thank you, Luis. And I think that that is really important because some of the trials are not including some of the populations, like for example, not people living with HIV, and there are some other populations that are harder to recruit. So I think that also the representation of the people inside of the trials, it's important to show them and to end some of the stigma. Um, so I don't have any more questions right now. So I just want to ask you, um, if someone, because that is, we talk about the education, and we know that providers need education. So what strategies people living with HIV and the Latino communities can implement, or what options they have if they to educate their providers? So what the community can do to educate their providers? If someone goes to an appointment and have issues with the provider regarding stigma or discrimination, what things can we do?
Well, in this case, I would like just to add something that we mentioned in other occasions, other opportunities, to have sensitivity to your clients, is to have a cultural approach. And when we say cultural approach, that doesn't mean just translate from English into Spanish. No, that is not a cultural approach. That is just a translation. But we need to approach culturally to the belief from our clients, okay? And that is something difficult. And some of the time, our medical providers lack of this approach. You know, they think that all the clients are the same. Women, cisgender, transgender, gay people, heterosexual people are all the same. And in fact, we are not. So something that, and Latinos are different, even into the Latino community. Caribbean community is different than South American community. So our health providers need to be aware of that fact. That is the only recommendation I can have in mind right now.
And also, I would like to say that actually having the knowledge that's powerful. It comes with a power. So I will first recommend for every person that is actually living with HIV to actually read about their the virus, to read about the treatment that are effective in order to live a healthy and longer life. Because actually, if you know all that information, you may identify when something is wrong in the provision of care. So that's the first thing that I will recommend. And the second thing is actually, if any person feels that it has been treated differently during the process, so we have the right to go and go to talk to somebody else at the manager level or at any other site that you are receiving care. And also it comes to play all of the community-based organizations, and it comes to play organization as the Latino Commission on AIDS, because actually the clients can go to the community-based organization to talk to them, to identify what other resources may I have to my ability in order to file a complaint, or to who else I may actually talk about the situation. And on top of that, I will encourage clients to reach out to the Department of Health and to the AIDS Institute. At the AIDS Institute, we are committed to provide or to make sure that every person that needs treatment, they are receiving the treatment as they are supposed to, without any experience of discrimination. So I will actually open up and I will give them an invitation that if they have anything that they would like to share with the AIDS Institute, they're more freely to do it.
Thank you. So we are, yeah, Anselmo, you're gonna say something? Okay, we are just on time to end this webinar. So thank you very much, Jose Javier, Luis Nava, Anselmo, and Dr. Carlos Rodriguez. He sent an email that he got an outbreak from the electricity got out of the.
Connectivity issues, yeah.
Yeah, so he was trying to connect through the cell phone, but he couldn't. So thank you very much for the information and also for be available to share with us this time here and to educate our community. And also want to thank to all the agencies that support our rally. So you can go to the hispanicnet.org as dash rally 2020, and if you click on the logos, you will go straight to the web pages, so you can find more information about their services and what they have to offer to the Latino to the gay bi men communities. So now to close, I'm gonna leave Luciano so he can do give us a little bit remarks to what's going on tomorrow also.
Thank you, Julio, so much, and thank you for panelists for share the information and for great and needed discussion today. Thank you, everyone, for joining and for your question. Please, if you have more questions, feel free to send them to me through email, and we can address that offline. Coming up next, we have another panel discussion tomorrow at 1 p.m. Strengthening the Latinx Gay by Men community with another group of fabulous panelists as well. So to register, please visit our website at www.hispanicnet.org/rally2020. And there you can also take a look at the virtual panel that Julio was mentioning. In a few minutes, you will receive an email with the evaluation link. We want to hear from you, so please take a moment to complete it. Also, the recording for this panel will be available in the website as well. So thank you so much and see you all tomorrow. That's all I have to say. Stay safe y se me cuidan. Muchas gracias.
Thank you. All right.
Thank
Bye.
you. Bye-bye.
Bye.